So it is my distinct pleasure and honor to introduce our next speaker, Dr. Christine Cassel. Dr. Cassel has been a towering figure in medicine for many, many years. She has served as the president of the American College of Physicians. She was the founding dean of a new medical school at Kaiser Permanente. She was one of only 20 scientists chosen by President Obama to be part of a scientific task force called PCAST. And she began her career as a geriatrician and a bioethicist, but she quickly became involved in the patient safety movement, which you know has many parallels to the professional satisfaction movement. And in that, she was a member of the committee that was the famous, that wrote the famous IOM report on To Err is Human. From that led to further efforts in quality as the president and CEO of the American Board of Internal Medicine and the American Board of Internal Medicine Foundation, and subsequently to the National Quality Forum. And Chris was telling me that one of her goals there was to decrease the burden on physicians. And I have a personal note to add here, because when Chris was the president of ABIM, she was the leader and funded a study called In Search of Joy in Practice that has subsequently, in many areas, kind of been the foundation for many of the interventions that we consider now around professional satisfaction and burnout. So I have a personal debt of gratitude to you, Chris, for starting me out on that journey in search of joy in practice, and here we are. Chris is a member of the National Academy of Medicine, and as a member, she then chaired the consensus report that was published in 2019, Taking Action Against Clinician Burnout, a Systems Approach to Professional Well-Being. And that particular publication, I think, has helped all of us move our frame away from considering burnout as an individual problem to a systems problem, that instead of focusing on fixing the worker, we focus on fixing the workplace. Or as the Feist said, rather than trying to fix the canary, let's fix the toxic coal mine. So it is my pleasure to welcome Chris to the podium, and please join me in welcoming her.
Thank you, Chris. These two Chris's have been working together for many years in many different ways, and it's really a pleasure to have her introduce this, because I kind of feel like, in some ways, Chris, I'm coming to your world, and joyfully so too, because I want to use my time with you today to step back and think about where we are. I've been attending the sessions today and really impressed and fascinated by all of the creativity and the activity. I agree, your head's exploding, all of these ideas. And I want to sort of use my time with you to kind of step back to look at, from the whole nation, what's going on, because that's the work that I'm privileged to do on this important topic, but also to kind of see where we all are. So this is the cover slide for the report that Chris mentioned, Taking Action Against Clinicians Burnout, a Systems Approach to Professional Well-Being. I put it up here to get us started, to remind you that this came out in October 2019, 2 months before the first COVID case in the United States. And at that time, we declared an epidemic of burnout in the United States. And so we sort of keep that 2-year, if you can even get yourself to remember what the world was like 2 years ago, think about that. But I also was reminded by talking to Jay earlier today that at that time when we were putting that committee met for 18 months, so it was basically, even earlier than 2019, 2017, we said what we hoped for was to see a movement for clinician well-being emerge. And I'm here to tell you this is it. I mean, you're it. And it's really exciting and really impressive. It may feel day to day like, I don't know if we're making progress, but even just looking at where we were 2 years ago, I can tell you it's inspiring. And it gives us hope. But I also want to point out that this phrase, which comes from Tom Naska, comes from Daryl Kirsch, the former head of WMC, a problem that was always there comes out of the shadows. And I think it is important to remember that. Tom Naska, I was thinking about Tom, who's head of ACGME, because at our very first meeting of the Consensus Committee, and his words will always reverberate in my mind, we're all excited, there's this new problem, we're going to tackle it, it's a National Academy Committee, and we have our initial hearing with the sponsors of the committee, and ACGME is one of them. And Tom gets up, he says, this isn't new. This was happening when I was in training, and he's older than I am. And it was happening when I was in training. And it was really an important, not to be a downer, but to say, finally, we're really paying attention to this really important issue. And also, at a time when the practice of medicine itself, for a whole bunch of other reasons, is changing. And so that was a very important observation, and now we're beginning to get national attention, public media, professional and trade press, educational institutions paying a lot of attention to it, delivery systems hopefully right alongside of them, and professional associations way on top of it, obviously. And part of my goal is to begin to get the regulatory organizations who are aware of this issue, but to come farther along. So as Chris mentioned, the report from the National Academy was seen to be in a series that started with To Err is Human and Crossing the Quality Chasm. 20 years ago, those books were published. And since that time, the Academy has put out, 20, 25 major reports related to quality of care and advances in quality of care, quality science, how quality has moved forward. And in their point of view, in their perspective, this report, Taking Action Against Clinician Burnout, is in that series. So seeing it very much as part of the learnings about how to improve healthcare system. You can't see this, but just to say that the National Academy reports have two ways of being funded. One is federal contracts. They just get a contract and they do a report. The other is they get some contributions from 3 or 4 big organizations to study a particular problem. This one was really unique because there were all of these organizations put in the money that made it possible to do this report. And it's almost all academic health centers, some healthcare delivery systems, a few, and ACGME, AAMC, other major societies, and then 2 foundations and 1 malpractice insurance company, the Doctors Company Foundation. So that kind of tells you even, that long ago, 2 years ago, there were a lot of people paying attention to this problem, and importantly, the beginning of a multi-dimensional and multi-sectoral coalition. And these are the people. I'm not going to go over this in detail, and I hope you will go on the website if you haven't seen this report, because you can download it for free on the National Academy website. But just to point out that people you know, Tate Shanafeld and Lottie Derby, were both members of this committee, but there was also interdisciplinary, so nurses, pharmacists, there was even a dentist on the committee, and importantly, and this was something I take a little credit for, a systems engineering human factors expert, Pascal Carrion, agreed to chair it with me. When Victor Zhao called and asked me to chair this committee, that was the first thing I said, Chris, was this can't be a report about yoga and meditation. As important as that is, we really need to think about this as systems. Why don't we go to the National Academy of Engineering and get somebody who understands human factors to work with us on this report? And Pascal is a wonderful person who many of you may know. So that was, I think, a great step forward when she agreed to join the committee. Now, we started with, you have to start with the definition, so we started with this definition, which you all know very well. Emotional exhaustion, depersonalization, and low sense of professional efficacy. We made it clear in our report that we are talking about a condition of the workplace. This language comes from the occupational health literature, not from the psychiatric literature, and that this is not a psychiatric diagnosis, that it is a manifestation of a chronic imbalance of high job demands and inadequate job resources. That's the definition of it. Now, since that time, there has been what I think is a very productive debate and discussion among the experts, among people like you, about, well, maybe it is a psychiatric diagnosis, or it certainly has some features, and we certainly see concerns about depression and seeking help and suicide. And how can we separate this out? So I'm not here to offer an opinion on that, but just to say that it's a very important discussion to have, but it can't take, providing help for people should not take our eyes off the need to deal with the chronic imbalance of high job demands and inadequate job resources. And of course, it does have psychiatric and psychological effects. And Tate, thank you for this nice little graphic. You know, it has professional impact, burnout has professional impact, poor quality of care, decreased patient satisfaction, lowered productivity, turnover among professionals, but it also leads to personal pain and suffering, as well as depression and suicide. So I think we have to really be very inclusive and think about the big picture. Now, speaking of the big picture, this is our Rosetta Stone, as you might want to think about it. This was the conceptual framework that those of us on the committee worked on for months and months and months to try to explain what we mean by a systems approach to healthcare. And some of you may be familiar with it, but I just want to quickly walk us through a couple of the observations here. One is that if you can see, and I apologize, I can't get it over to that screen, but if you see this little white circle in the middle, that's individual mediating factors. That's resilience, that's personality, that's personal resources. It's not unimportant. All of these external factors are filtered through that to end up with either burnout or well-being. But what we think is that this shows you how inadequate it is to just focus on those factors. So there are three primary locations for the sources of the job imbalance and the drivers of burnout. One is the frontline care delivery system. So this is your clinical unit, the emergency department, the intensive care unit, the clinical setting in the outpatient setting. And there's a lot that people can do within those environments. I've been hearing about it all day today to try to address that environment and how it can either contribute to burnout or contribute to well-being. The green circle around it is the healthcare delivery organization. So think about that. That's your hospital or health system CEO. That's the big organization in which workers work. And they're the ones who sort of set the policies for how certain things get done, or how compliance gets handled, or what kind of investments are made in clinician well-being or in systems redesign. So that's the sort of at that level. And then the outside level is the external environment, and that's these days where I mostly live, and it includes the regulatory agencies, the healthcare payers, the state licensing boards, and what we've learned from COVID is it also includes the public and society's attitudes about healthcare, and also, as we see with COVID, about taking precautions and other kinds of things. So that's that external. All of those things matter. You can't say that one of them is more important than the other, but some people will look at this diagram and say, it's too complex, it's hopeless, there's nothing you can do. I think the answer is exactly the opposite. It's so complex, there's a place for everyone. If you just look at where you live and where you work and what your connections are and where your passion is, there is some place in this diagram where you can make a difference. So our conclusion then was that collective and coordinated action against all levels of the healthcare system is needed. So it's not enough to just do one thing or another thing. So the report is very expansive and talks a lot about all of the different areas. And I'm not going to go into a lot of detail about the report. If some of you are familiar with it, if you haven't read it, you can find it online. But we based it around these 6 goals. And they too sort of take the different pieces: create positive work environments, create positive learning environments, because the issues for educational institutions are somewhat different, but equally important. Reduce administrative costs, enable technology solutions. I'm going to talk a little bit more about that. Provide support to clinicians and learners. So that comes from teams, it comes from other sorts of coaching and efforts we heard about earlier today. And of course, it wouldn't be the National Academy if we didn't say invest in research. And of course, in this area, that's really vitally important, because there was so much in our report that was limited because the National Academy will only publish a report that is evidence-based. And there were a lot of areas where there wasn't a lot of good evidence. We're now seeing more and more good research in the literature, many of it coming from you. So keep it up, because we really need that. And then finally, so those are the goals. What are the implementation steps? And again, this is very big picture. But first, think about infrastructure. Think about the things, what the British call the pebbles in the shoes, the things that create the possibility to get the work done in a better way, and that kind of get out of your way. Secondly, design reward systems, and that has to do with how we pay people, but also has to do with professional values and how you recognize, how we recognize one another. And that, of course, relates directly to organizational culture. I've heard a lot of talk about culture today. Culture change is not easy, but it's essential, and it's beginning to happen. And so I think that's a real important part of the work all of you are doing. And in all of this, use human-centered design processes. So don't just think about how do you get more efficient, but think about how does it affect all of the human beings who are part of that process. Okay, that was 2019. Those were our recommendations in October 2019. Now here comes COVID. it adds to this tremendous, what we already declared as an epidemic. And these are just some of the things that what happened to me in my life during COVID, and I'm sure all of you. First, there was a lack of knowledge. That's the worst thing for doctors. I mean, we had this disease we knew nothing about. We didn't even know about proning. We didn't know whether steroids helped or didn't. We didn't have any treatments. We had all these sort of fake news floating around, and people were dying down there. Just unprecedented mortality rates, and just heartbreaking, agonizing. Secondly, infectious risk to yourself. I mean, I remember I was a resident at UCSF during the early days of the HIV epidemic, and there was this nervousness, but that was about finger sticks and things. Here it's just about breathing the air, just about being in the same room with someone. And so that added to it. And then the institutions, this gets to that circle, the institutions in which we work didn't have enough supplies, didn't have enough PPE to protect the workers, but also didn't have enough of what it took to actually take care of all these terribly sick people. So people were faced with moral challenges and real moral distress about rationing, about making decisions about not just ventilators, which got a lot of attention, but every little thing, including human beings, including if you're a nurse, which patient are you going to go to when you're taking care of 8 patients in the ICU when usually you had 2? So all of that. Plus, it laid bare what we already knew, these stark inequities in our healthcare system, but really sort of brought it to everyone's attention. I mentioned moral distress and moral injury, and all of that. So if you think about the external circle in our diagram, all of that in the context of this poisonous political debate about people saying it was a hoax and all of these kind of misinformation floating around. And yes, there were the people who were cheering the heroes, but the other messages for lots of people going home from these terrible shifts was people not wearing masks, people not caring. So all of that was just a tremendous, and I don't mean to kind of create PTSD by taking us all back there to 2020, but I think it's important to remember how shocking it all was. But one thing that it did, it elevated the levels of burnout. There's no doubt about that. But it also elevated the levels of awareness and concern about burnout. We have the attention of the nation now in a way that, well, I mean, we might have had some success with our report, but boy, now it's really top of mind for the public. And so this slide, I apologize, it's too small for you to see, but this is the Clinician Wellbeing Collaborative. So the group that got the report together was a collaborative of organizations that included AMA and ACGME and AAMC and many of the leaders in this room and in this organization. And that group, one of the things that happened with COVID is they said, we have to keep going. They raised the money, expanded the collaborative to a lot more people, a lot more organizations, and had a Surgeon General, who you heard from this morning or yesterday, Vivek Murthy, who's very supportive, very interested in this, and agreed to co-chair the collaborative. So we now have at the national level a very powerful and influential person as part of the leadership of this organization. So this was our sort of strategy for 2017, and I see people taking pictures, but I'm happy to leave these slides with you and share them with you. From 2017 to 2020, was the work of creating the report, engaging leaders, beginning to identify best practices, and a lot of the work that you've already seen going on. The next stage, with the Surgeon General as a co-chair, was focused on building a national strategy, leading a comprehensive approach to addressing COVID, and identifying tools and creating, and Chris has been very involved in this, in creating a toolkit for CEOs who understand now it's a problem, but they want to know what to do about it. They don't want to read our 400-page report. They want 5 things they can do. And so we've got people, really good people working on that now. This is just to show you how many, I've even lost count. I don't know how, there's like 100 and some organizations involved in this collaborative now. So it's really very exciting. And this is our work plan. So I want to show this to you. This is an internal document, but I think it's okay if I show it with you, because it's one thing to talk about making these changes at the national level, the federal level, but we actually are doing it. And so we have a plan. And so this is sort of the steps along the way that the convening. So one of the ideas is to get really leadership people together. You know, and the Surgeon General invites you to a meeting, generally you come. So it's a very helpful situation. And we're focusing on 3 major groups. The first one is CMS and other payers and heads of delivery systems, either CEOs or perhaps CIOs, to talk seriously about documentation and documentation pressures. One thing is to look at the changes that were made to the E&M codes just at the beginning of this year and to ask, did that make any difference? Did that have any impact? And then where can we go from there, not just to stop there? So that meeting is in the works. The next gray block, which you see in January, is related to accreditation. What could the accrediting bodies do to help stimulate organizations to pay more attention, to do more for clinician well-being? So, for example, Joint Commission. If clinician well-being were part of hospital accreditation, what would that look like? And of course, I'm always mindful, you want to do it without adding more measurement burden. You want to think creatively and differently about it. But Joint Commission is in conversations with us, and we're talking with them. But it's not just the delivery system, it's also the payers. So we want to bring NCQA into this and other accrediting organizations to think about, of all of the things that they put on their dashboard for whether or not you get accredited, where is clinician well-being in that dashboard? And then the last one, at least in our plan for the coming year, because we hope that there will be more after that. But the last one is convening health information technology entrepreneurs and innovators about how can we've seen this happen in other industries, how can we take advantage of the tremendous power of electronic digital science, which has come to be seen for many physicians as an enemy, as a problem, rather than as a problem solver. And yet the tools are enormous when you think about not just voice recognition, but ways that information can now be taken from EHRs and digested and turned into more clinically useful information, and all kinds of things that we've learned during COVID, of course, because of things having to be done remotely. And then I think, Chris, I'm putting November there for the resource compendium. I don't know if that's going to be on target, but close to it. And then we're also going to have 2 meetings actually from our COVID group, one on convening leaders about how to really embed well-being as a value in the healthcare system. So this gets to do with the culture part, and then publishing in the spring a kind of a white paper on the lessons learned from COVID about well-being. And that's where the funding takes us, is to the end of 2022. One of our challenges is to figure out how this movement can become sustainable. This organization is obviously going to be key to that, but to try to raise the money to do that. So I'm going to, let me just look at the watch here. Oh, good. I want to spend the last few minutes kind of exploring what to me are some of the more interesting areas to put on the table, and then have some time to hear from you, both comments and questions and ideas. So this is, as someone who spent a lot of my life in the quality of care movement, I always tell people, when I went to the National Quality Forum as the CEO, I didn't think of myself as the chief burden creator. But some people actually started calling me that once we started having this discussion about burnout. And I struggled there because one of the things I saw was this proliferation of metrics. When I got to NQF, CMS, even just Medicare, had 8 different measures for hypertension. And it was very confusing about which to use for whatever. So we worked on getting that down, and I was quite successful at that. We then got CMS and the insurance industry, the AHIP, together to try to see if they could use the same measures for their documentation. Well, it turns out, that the insurance companies have 3-year cycles for their contracts, and they couldn't change this. And it was like a forced march through measurement. I mean, we would get together and we would do these 3 measures this meeting, and then we would do these. We did make progress, I'm telling you, but it wasn't the kind of sweeping progress that we probably could make if the whole healthcare industry got together and decided to make some of these changes. But nonetheless, it's really important. And then, of course, there was this whole proliferation of other people measuring, some of which didn't require physician documentation, but was very erosive to the culture of medicine. Here I'm thinking about Yelp. Instead of even going to Medicare Compare, as inadequate as that was, people would find out who's a good doctor by going on Yelp, and here you are agonizingly entering all this quality data so that somebody somewhere could understand quality data. So, that didn't help either. And then this statement, what is measured is what matters, and of course that's kind of the mantra of the quality movement. But we ended up a lot of times measuring volume and checkboxes, not compassion or creativity, and that's still a challenge, how we're going to do that. And so that's one of my personal goals, is to continue working with policy leaders to see if we can figure out to partner with modern digital technology and see about if there's a way to make this whole thing go much more smoothly and, frankly, be much more meaningful to patients as well as to clinicians. And so technology innovation, I think, really is an important part of it. We're all familiar with voice recognition software. It's getting much, much better. And video recognition software is now also possible. And there's what I want to spend a couple of minutes talking about information technology middleware solutions. Now, this middleware term refers to software that can go into your EHR and pluck out the data that you want and turn it into something that's useful to you. And that's now very possible. There are a number of companies doing it, some of them better than others, some of them working in different ways than others, but it was made possible by a single policy change from the Office of the National Coordinator of HIT 4 years ago, which was the 21st Century Cures Act, in which they required the EHR vendors to open the APIs, to open the technical interfaces so that they'd have to share data. It's basically what we call interoperability. Now, the way the language is written is primarily so that patients can get their data from whatever doctor they go to. But what it meant is that a lot of creative young entrepreneurs began to make deals with Epic and Cerner because now they couldn't hide, and they got the data together to create these much more useful ways of digesting the data. That doesn't change how the data goes in. I mean, we still need to look at voice recognition and other ways of doing that. But in terms of the usability and how many hours you spend sitting in front of the screen trying to find different kinds of information, it can be hugely helpful. And then finally, one of the things I'm very excited about, and I spent a fair amount of time on during COVID, is how inadequate the data for public health is in the United States. And, you know, we saw that during the whole pandemic, that, you know, the best data we were getting came from academic institutions, not from CDC, but nobody had a coherent view of the country the way that other countries with national health systems were able to say, this is how many cases we have, this is what's trending, this is what's not. So we still have the potential of being able to use electronic health records as a source of more credible public health data. And then the last thing is public health. And I just want to spend a minute on this because, you know, I have a background in medical ethics. And so one of the things that living through this pandemic made me think about was the concept of a social contract, that Justice Brandeis in the early part of the 20th century described the professions as having a social contract with the public, that the professions would get autonomy and prestige and respect from the public, and in return for that, they were to provide a good, some kind of good or service for the public. And he had in mind here doctors, lawyers, and clergy. Those were who he considered to be the learned professions. Well, we've come a long way since then, but I think there still is this idea of the social contract when we think about some of the ideas of self-regulation, of board certification and other kinds of things, that comes from that notion that the public trusts us. And so therefore we are allowed to have this, it's this status and frankly the economic well-being that we do. But in some ways that kind of broke down during COVID because what you had to do is go in every day and be a hero and then not get the support from the public back, either in terms of tangible stuff like enough supplies and what you needed, enough support from the government in establishing crisis standards or other kinds of sort of public things, and as I said earlier, from the whole sort of public environment. So it made me think about what do we really need from public health to enhance clinician well-being? Well, I think one thing we need is preparedness and adequate supplies. We absolutely have to be prepared for the next time some disaster happens, and we need our clinicians to step in and do the work that they do. We also absolutely need accurate and complete data availability. We need collaboration between systems. Somehow in this competitive market of healthcare, we have to figure out the incentive that really stimulates collaboration. And we need consistent supportive messages. And I put crisis standards of care there just because I see that as an example of where government can step in when needed and have your back and sort of say, these are the guidelines. You're not flying blind. You don't have to make these agonizing decisions one by one or in isolation. And so there's a place for public health, a partnership between public health and medicine as we think about clinician well-being going forward. So I'm going to end with that thought and leave you with the link to the National Academy Report if you want to go to that, and also the link to the resilience, the Clinician Wellbeing and Resilience Action Collaborative. And I urge you, if you do anything, to go there, because there's all kinds of tools and resources. Many of you may have already found it, but it's growing with all of this work that I just told you about, and we hope that there will be much, much more. Thank you very much. Questions, comments?
Thank you. This is really exciting. Thanks for coming to present today. My name is Nigel Bjerger. I'm at Ochsner Health in the Gulf South. I wanted to maybe pose a question, a similar question to one I asked yesterday when we had a really outstanding talk from Corey and Jennifer Feist, who lead the Laura Breen Heroes Act. And
could you take your mask off while you're talking? It's hard for me to understand. Right, thank you.
Sorry. When I reflect on influencers of behaviors for delivery systems over the past decade and carrots and sticks, certainly the sticks are the regulatory agencies over quality and safety. But the carrots are often rating agencies, and I was just wondering if there's anything the group can do to try and influence how they look at clinician well-being.
So you're thinking about things like different approaches to payment for
U.S. News
services.
And Report and similar things that CEOs pay a lot of attention to.
Well, they're actually in our report, we talk about that, and it does come up often in this group. We haven't specifically focused on that, but we do talk about it a lot, the group that I'm in, and I agree with you. I think that there's a lot of what has created this sort of hamster wheel approach to medicine and the need for all this documentation has been the fee-for-service system and sort of the different ways that it's implemented. So I think a lot of people are having that discussion, and you know, I agree with it. It's a very important one.
Thank you.
Other comments, questions?
While we wait for others
Cries of distress?
Chris, while we wait for others to possibly form their thoughts, I had a question that came to my mind, and it has just left my mind. So I'll need someone else to raise their question so I can bring that back.
Okay, here we have
I'll save you, Chris.
Thank you, John. I appreciate that.
Maybe I could just follow up with a question that I asked yesterday around, I guess, payment reform, and I was very excited to see your mention of that. So do you have a sense of what the hurdles, barriers might be that would lead to some change in terms of payment reform in which well-being is incorporated, and that certainly could be thought of as a carrot, maybe a stick, I guess, as well, but certainly an incentive one way or the other. What is it going to take to get CMS to think about this in the same way they think about other metrics that drive compensation?
I'm with you. I think there now is a moment of opportunity, I would say. You know, the people who are there now are understand this issue. They've set up a whole separate department within CMS about, I think it's called burden reduction or something like that. So I think with enough concerted pressure, that's what I'm hoping our group will do in terms of being able to pull people together with the bully pulpit of the Surgeon General. But, you know, I think all of the professional societies need to be on this right now, because this is a moment when we have the attention of the public. And now the issue there is everybody's going to have to, you know, the problem with our system is that every group goes and lobbies the thing that they want. And so that makes it hard for CMS to really make any sweeping changes, because that, you know, they have, somebody will be unhappy with it. But I think there are a number of things that could be done without legislation within the purview of, for example, the innovation in the CMMI. And Medicare has all kinds of ability to try out innovative things. So this is really a moment when I think all of us who have any angle into the payer world should really be thinking creatively. And I hope that, you know, that there's a lot more of that. Major changes ultimately involve Congress, and that's, of course, a much tougher lift. But on some level, if you get CMS behind it, it makes a huge difference. Yes. Hi,
Hi, Chris. Jay Kaplan from LCMC Health in New Orleans. We've talked, let me see if I can weave a couple of things together. Number one, I loved your note about the fact that what we measure is what's important, and that I would love to say that we could somehow incentivize. The issue of incentives is also important, and it's not just in terms of the practicing clinician, it's also in our academic centers.
Yeah.
Does publishing or does clinical teaching get incentivized? And I would love to see, going back to the whole issue of how important language is, I would love to see us, instead of having a pay-for-performance program, how about a pay-for-compassion program or a pay-for-wellness program? You know, and in the same way, where other countries pay physicians to have their patients stay well, I would love us to somehow develop a program where we could pay our physicians to stay well, which then could help them help their patients stay well.
Instead of an HMO, you'd have a clinician well-being MO. I'm with you on that, and that's where we're sort of beginning to get with talking to the accreditors, you know, to the Joint Commission and others like that. But then it's always, you know, what it comes down to is how are you going to measure that compassion, right? How are you going to, and hey, that's the opportunity for great creativity. I don't think it's impossible. And I think in some ways it might be much more meaningful to patients and clinicians than all of the little, you know, check boxes that, you know, we too often do now. Yeah.
So, Chris, the question I'd like to ask, and Mark, we'll give it back to you, is you mentioned the social contract, and I'm thinking of Daniel Pink with autonomy, mastery, and purpose as some of the conditions that drive professional satisfaction and well-being. And when you and I first became physicians, I think there was more autonomy, mastery, and purpose possible. And what I've noticed is that over time, we have removed decision authority from the physicians closest to the patient.
Right.
And so I'm wondering if there's anything that you can think of that we can collectively do, particularly from a government point of view, regulatory point of view, a conceptual point of view, that helps to push a little bit more decision authority for the work environment in which physicians work back to the people closest to the patient. Mm-hmm. Because I think we have these really highly trained people who feel like automatons. So that's the question I want to throw to you before I turn it back to
you know, there's a lot packed in there, Chris, because there's so many changes that have occurred over history. But one is just getting back to the fee-for-service system. I'm thinking about Rick Kroenig, when he was head of AHRQ, published this paper called The Apple Picker and the Supreme Court Judge. Do you remember that? It gets at the Daniel Pink thing. He was talking about if you want people to pick apples, then paying them per apple makes a lot of sense. And he used Supreme Court judge. I don't know this day and age whether that's the right analogy, but if you want a judge to be a good judge, you don't pay them for the number of cases they produce, right? You give them a certain amount of accountability or whatever, and you pick the right people, you give them a salary, and they do their work because they're professionals, and they get rewarded for that. And he makes exactly the same argument that Daniel Pink does, that if you have people who are doing complex work, they work much better under circumstances where they're not being on an assembly line or being paid piecemeal. And that observation has been around for a while, and I think we continue to sort of talk about it and move little by little. But if I look at the VA system, I'm doing some work now with the VA, or Kaiser Permanente, another place where I have a lot of experience. It really is a very different environment for the clinicians in those environments because they don't face that pressure. So I think those are important lessons for all of us. Yes.
Dr. Cassel, thank you so much for your presentation, more importantly for your leadership over the years and on this issue. I was struck, very pleased by how you called attention to the importance of emerging and continued dialogue and collaboration between the clinical side of our collective profession and cosmos, I'll say, and the public health side. It's not lost, I think, on many of us that there was some good collaboration and there's some opportunity for rapprochement and learning moving forward. Can you speak to that in some more detail, please?
Of the collaboration between the clinical world and government.
Public health,
or public health
systems,
yeah.
And clinical delivery systems.
This is sort of my hope for where some of the next steps in this process might be, because it's one of the things we've started talking about it even pre-COVID, but especially as social determinants of health, right? And for many physicians, actually I was just talking with Lisa Rottenstein earlier today about this, among the many sources of moral distress is taking care of patients with tremendous social needs and not being able to do anything about those social needs that actually impact their health more than anything you can do, and how painful that is for a physician. In many other countries, public health and medicine are all together. It's in the same medical school, it's the same education, and it's all part of the same system. And I think it's another place where a lot of our renewed attention to social determinants of health can help that strengthen that partnership. What has to happen, though, is also at the level of government, because right now, public health is starved for resources. It gets no money, which is why it doesn't have the ability to meet the needs that it ought to be meeting, or even collect the data that it ought to be collecting, because we put so much money into the medical care side of things. So, that's a really important discussion, that if we want to end up with healthier people, that's going to be where we have to go.
So we have time for one more question, and Tom, you'll have the last question.
Thanks, Chris. And Chris, nice to meet you in person. Tom Savides from San Diego. Many of us are here from academic institutions, and the National Academy of Medicine obviously is composed of mostly academics. From a research point of view, are there agendas or items that we should be focused on? If you're a young physician going into this area, what should be the areas that these people should be going into? And the HRSA grants from the summer really showed the interest, and will there be more HRSA type grants coming for the future for research?
Thank you, Tom. Nice to see you. We have a group that have been meeting on Zoom, and so we, for the first time ever, have met each other in person at this meeting. So You're absolutely right about the research, the importance of the research agenda, and that's why it was an important part of our recommendations. There's now been this one grant announcement from HRSA, which I'm sure you're all aware of. I'm really hoping there's going to be a lot more where that's coming from multiple different agencies, not just from that one. And in terms of a research agenda, I'm not the one really to pronounce on that. There are a lot of people in this room who are really expert researchers in the area of clinician well-being. But I think coming together, people who have interest in clinician well-being, coming together with health services researchers who understand healthcare systems and economics, and just some of the things that Krasinski was just talking about. There's some really wonderful interdisciplinary collaborations that could be possible here to shed light on this important question of, well, what do we do? We know about this problem. What do we do about it? The fact that it seems so complex is discouraging, but it actually, there are a lot of places in there where really important studies could give people some guidance for where to make policy changes. So I encourage everyone to keep up the good work that you're doing.